Hello, my name is Mark Reynolds and I'm an Associate Clinical Educator with Meducate Academy. Today I'm going to take you through a sort of textbook cardiovascular examination for teaching purposes. I'll be doing a lot of things that you might not need to do in clinical practice, but at least it'll give you an idea of how the full examination is carried out, and you can take from it that which you need. So first of all, I'm going to wash my hands and introduce myself to our patient. Hello sir, my name is Mark Reynolds, I'm an Associate Clinical Educator. I've been asked to carry out a cardiovascular examination on you today. Could I have your name and date of birth?
Yeah, it's Bob's birth, 30th of the 8th, 56.
And how old does that make you?
63.
And how do you want me to address you today?
Bob's fine.
Have you ever had a cardiovascular examination before?
No.
So does it involve me looking at your hands, looking at your face,
Okay.
examining your chest,
Yeah.
listening to your chest,
Yeah.
stethoscope?
Yeah, that's fine.
Is that okay?
Yeah,
You should move about a couple of times as well on the couch.
I'm happy with that.
Okay. Could you, for the purpose of this examination, I need to be able to see your chest.
Oh, okay.
Would you be able to take your polo shirt off for me?
Yeah, of course I can, yeah.
I'll look away while you're doing that. Let me know when you're ready.
Yeah, I'm ready now. Yeah, I'm ready, Mark.
Thank you very much. Right, so end of the bed inspection. Bob looks comfortable at rest. He's breathing normally. He looks well perfused. He's not in any respiratory or cardiac distress. Okay, I'm going to take your hand. Your hand is nice and warm and well perfused. Now, in a standard cardiac examination, we can look out for signs of high lipids, signs of anemia, and signs of poor oxygenation. And these present themselves in the hands, face, and eyes. So first of all, capillary refill. Hold firmly, press for a couple of seconds, let go, comes back in 2-3 seconds. That's normal. Could you do that for me, please? Put your fingers together like that. This is for Shamross window, which if it wasn't present would be a sign of poor oxygenation. Thank you very much indeed. Look at the nail beds for koilonychia, hollow nail, sign of anemia. That's from the Greek hollow nail. Any leukonychia, white spots. Any signs of xanthelasmas around the finger beds. Any signs of peripheral cyanosis, any blueness around the finger bed. That looks okay to me. Turn over, look for signs of Janeway lesions or Osler's nose, indicative of infective endocarditis. They're either painless red spots on the palm or painful red spots on the fingertips. Any signs of palmar creases for anemia. Bob's hands look absolutely normal. I'm going to move up now and very quickly take a radial pulse. I could have a timepiece with me, I could time it. Fundamentally, I'm checking to see whether the pulse rate is regular. If it isn't regular, is it irregularly irregular or irregularly irregular? Bob's pulse is beating normally, that's fine. I'm going to take both pulses now, and I'm checking for any radial delay, which would be indicative of aortic regurgitation. Bob's pulses are both beating at the same time. That's great. Bob, do you have any pain in your shoulder?
No, not at all.
I'm going to check now for something called collapsing pulse. So I'm going to very gently, firmly take hold of the radial pulse, and then I'm going to very briskly lift up Bob's arm and see if there's a tap, 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 tap back against my fingers, or is the pulse normal? If that tap, tap, tap was present, that would be indicative of a constriction of the aorta, but the pulse is beating normally. Thank you very much indeed. I move up the arm. I could check here for the brachial pulse, medial to the biceps tendon, which is a good pulse to use for volume. And at this point, I can also take a manual blood pressure, but this is covered separately in one of the other of your training videos. Moving up now to Bob's face, I'm looking around Bob's face. Could you pull down an eyelid for me, please? Looking for any signs of conjunctival pallor, which would be indicative of anemia. But Bob is nice and well perfused. Thank you, let go now. Looking around Bob's eye for a corneal arcus, a silvery ring around the iris, which can be indicative of high cholesterol. This also occurs naturally in the aging process, so it's more of a red flag in younger people. But do get people checked out if you see it. Looking around the eyes for xanthelasma, fatty deposits of cholesterol. And Bob's eyes look fine. Could you open your mouth, please, Bob? Could you lift your tongue into the roof of your mouth? Looking for a high arched palate. Looking for any central cyanosis. And that looks absolutely fine. Now, if Bob had blueness around the lips, central cyanosis, and reddening of the cheeks, flushing of the cheeks, I'd be concerned with that for mitral stenosis. So look out for that as well. Also coming back to Bob's hands very quickly, as I ought to remember in the cardio exam, we're looking for red flecks in the fingernails, Janeway lesions, which are a red flag indicative of infective endocarditis. Thank you very much indeed, Bob. Right, Before I use the stethoscope, I've got some palpation to do. I want to find Bob's apex beat, which is the furthest out heartbeat which is palpable in the human. It's located at the 5th intercostal space on the midclavicular line. So starting here at the sternal notch, move down to Bob's angle of Louis, where the sternum gets a bit bumpy, move down 2, 3, 4, 5, move across the 5th intercostal space, midclavicular line to find the apex beat. If you have trouble finding the apex beat, ask the patient to lean to the left. Could you do that for me, please, Bob? This brings the heart nearer to the chest wall and finds the apex beat easier to find, and that is not displaced. Thank you very much indeed. Staying in this location, I'm going to feel across the 4 heart valves now for heaves and thrills. So in this motion, moving across the 4 heart valves, I'm feeling firmly for heaves and thrills. A heave would be an abnormally large pushback against your hand with a larger heartbeat, and a thrill would feel like a murmur under your hand, like a purring of a cat. So these are palpable, abnormal large heartbeats, or palpable murmurs. Okay, Bob, I'd like to check your jugular venous pressure now. This involves me asking you to look to your left, please.
Okay.
And this will be raised in right-sided heart failure. So look in the triangle here by the sternocleidomastoid joint muscle and see if there's a flickering, and that looks absolutely normal, so nothing to worry about. And come down to the level as well and look across so you can see it properly. Normal slight flickering, no problem there. Thank you very much indeed, Bob. If you could sit forward for me, I think we'll check your hands for splinter hemorrhages. Little red flecks in the nails, splinter hemorrhages, indicative of infective endocarditis. If you spot those, pass on your patient to an appropriate healthcare professional. Right, I can now get on to listen. Before I do that, could you sit forward for me, please, Bob?
Yeah, of course.
And lift your arms. So looking around Bob's chest, no signs of any previous surgery, no pacemaker implants, no redness, no scars, no swelling. Thank you very much indeed. So for a cardio exam, for a basic cardio exam, we use the diaphragm, which picks up higher pitched sounds. So earbuds facing forwards, make sure the diaphragm is live. And we listen now, I'll just take this off for a moment, we're listening now for the 4 heart sounds, which radiate around the chest in the following areas. So using once again angle Louis as our anatomical point, we move across naturally into the 2nd intercostal space on the right sternal edge, so off the sternum, that's the aortic sound. Moving back across 2nd intercostal space, left sternal edge, the pulmonary sound. 4th intercostal space, left sternal edge, the tricuspid sound. And 5th intercostal space, midclavicular line, the point of the apex beat is the mitral sound. So we listen with the diaphragm, and what we're listening for are heart sounds 1 and 2, lub-dub, lub-dub. We're concerned with any extra sounds. We're concerned with a whooshing sound, for example, so lub-whoosh-dub, lub-whoosh-dub, which would be indicative of a murmur, and this person would need to be referred on to another healthcare professional. So the aorta, pulmonary, tricuspid, and mitral. Heart sounds 1 and 2 present and correct, lub-dub, no added sounds. Okay, Bob, could you sit up for me, please, and swing your legs around to the side of the bed?
Yep.
I'm now going to auscultate Bob's lung bases for any crackles. So the base of the lungs, I'll ask Bob, please just cross your arms, open up your scapula for me. When I place the stethoscope on you, could you just breathe in and out through your mouth, please?
Mm-hmm.
And again, please. And again. And one last time. Thank you. Whilst in this position, I'll check Bob for any sacral edema. So quite low on Bob's back, I'll press very firmly with 2 fingers, hold and let go, and there's no sign of indentation from my fingers, no signs of sacral edema. If you could pop back on the couch, please, I'll just roll the sock down. I'll check for pedal edema by pressing on a hard surface like a medial malleolus. Once again, holding firmly, taking my fingers away, and that's absolutely fine. Thank you very much indeed, Bob. You can put your polo shirt back on now.
Okay, thank you.
That was an unremarkable cardiovascular examination for Mr. Spohr, and thank you very much for watching.